Hello, everyone. Happy Friday. I think the team can tell that I have a little bit of a buzz in my step for so many reasons, both outside of this space, 'cause I had an absolutely incredible 6 a.m. sunrise run with my doggy in beautiful weather, but also because it's just so cool what's happening today. Not in the least is because I finally get to hear Manahil doing teaching points. I've missed two of her most recent sessions, so very excited to actually hear her live. Let me hand the mic to her to say a quick hello before I tell you more.
Hello everyone, I am Minahin, IMG from Pakistan and very excited for Seema's case and Kirtan and Rabih's discussion.
Manaha, we're going to keep you very, very, very busy today because, yes, we're thrilled to tell you that I get to co-discuss with Kirtan. But before I shed light on that, I want to give a huge shout of gratitude for Julia, who's doing the scribing today. Julia, what's new with you?
Hello, everybody. I am nervous. It's Friday and you both are discussing. It's gonna be a rich case, and I'm so excited for it.
I think you have good reason to be nervous, honestly, because Simi is hard at work presenting a case. I will tell you that in many medical spaces, it's a little bit frowned upon to work when you're on vacation, but in this space, I think that it is totally and wholly accepted. Of course, everybody wants to have a work-life balance, but I think for many of us, we find joy and actually relaxation and reflecting on medicine. And so I'm here to tell you that our newest Academy member, Simi, is presenting a case. Not only is she doing so last minute by volunteering to step in after a last minute vacancy, but also is doing it on her vacation, which I think speaks leaps and bounds to the character that she is. So, Simi, I'll hand the mic to you to say hello, and then we'll all douse Kirtan with some praise at the end.
Hello, everyone. I'm very excited to present today and happy Friday.
I love
So,
that. I love that. You're very, very, you're very, very concise. Tell us, how has your vacation been so far?
yeah, my vacation has been great, and I have been attending some sessions with the Academy as well because I think it's fun to have vacation and my CP Solvers family with.
Thank you for taking us with you. We really, really appreciate it. And speaking of CP Solvers, my mom is calling me. I'll have to call her back. Speaking of CP Solvers family, see, Kirtan, it's official. You're officially more important than my mother. I just shut the phone on her to talk to you. And the reason for that is all of you should know. I've met Kirtan when he was a medical student. It seems like many, many, many years ago. And it's been incredible to see him grow and take up space. I think all of you know him, and he carries a reputation larger than his physical size for how knowledgeable he is. But what you don't know is just how incredible he is in terms of developing his teaching skills. He's become a master teacher, and I think that combination is deadly. But I think all of you might stereotypically think that somebody who is so nerdy may not be socially graceful, but that is the exact opposite of Kirtan. I'm learning his behind the scenes secret network. I think he privately messages every CP Solvers team member to check in on them, share cases with them, and I'm only starting to learn that. So not only is he a gem when he analyzes medicine, I think he keeps his eye out for people, looks after them, and so how no better way to celebrate him than to have him fill Prof Rez's shoes, and I think they might feel a little bit tight, honestly, given how large your feet are. And I'll tell Prof Rez that. But at the risk of irritating our YouTube viewers, I'll stop talking now and hand the mic to you, Kirtan, to say hello, and then we can jump in.
Sure. Thank you so much for the kind introduction, Rabi. And I must say that my teaching skills are still juvenile compared to RLR. So I'm still following their footsteps, learning from them. And I must say that today I needed the warmth of all of you guys because you won't believe this. So it's freezing in Chicago. It's snowing right now. And my heater has broken since yesterday. It's not working. I put the emergency request, but nobody has come yet. So I am like keeping blankets around my feet and stuff. So let's see how it goes. It will be like literally discussing in the freezing temperatures. So I'm excited for that.
Well, hopefully Simi has a case of hypothermia for you to keep it even more in tune, but we'll see what she has. Take it away, Simi.
So, I have the first record with you. We have a 33-year-old woman with weakness, and she is in comatose state on mechanical ventilation. And I'll also give some history of presenting illness. The patient was transferred from outside hospital with diffuse weakness. She was in her usual state of health 11 days ago when she developed weakness, urinary incontinence, subjective fevers, and intermittent vomiting. And I'll stop here and I would love to hear your thoughts. And Robbie, one thing more, I have color coded with you today. We are both team green.
I know we are both team green, and I even underneath am team green. So yes, let's do it. Kirtan, what are you thinking of so far?
Perfect. So whenever we see a young person who is in such a bad state, we start panicking because we have to figure out that why such a young person who should be otherwise healthy is suddenly in comatose state in a span of 10 days. If it was a chronic illness, then we might have a more time to think, but this is so sudden that we might wonder that if we don't do something right away, we might lose the patient. So there is some sort of urgency to the management as well in this case. So getting the more data down the line from CMA would be very helpful to know that does this person have any relevant past medical history? Does this person take any routine prescribed medication or over-the-counter medications or any kind of drugs which could have caused this? But if we don't have that information yet, then how should we frame this? So firstly, we can say that this young lady had a prodromal illness, which was characterized by sore throat, weakness, and some degree of subjective fevers. And within a rapid time span, I would say this will be acute rather than hyperacute. So acute degree of encephalopathy. So it's very important to understand the anatomy and physiology of how you can have symptoms, and then you can dig deep in the differentials. So whenever we use the word comatose state, what do we mean? We mean that person has loss of certain brainstem reflexes and is unresponsive on clinical examination. So which means that at the basic level, you are dealing with global dysfunction, probably at the level of brainstem. So what are other brain centers which could be involved when you have loss of consciousness or comatose state? So ideally, people say you should have brainstem involvement, bilateral thalamic involvement, or global cortical involvement. So you could have pathology at any of these three levels, or at all of those levels to cause comatose state. So now our job is to figure out that why would any of these centers be involved in such a rapid fashion following an infection. So the common theme could be that maybe the infection triggered an autoimmune attack towards the cortex or towards the neurons, which is causing this comatose state. And we know that it can happen in a variety of illnesses. And some of them can also feature weakness and urinary incontinence in the prodromal phase. And then the autoimmune attack transfers from peripheral nerves to the central nervous system. So that could be one common way to tie in. Other possibility is that we are dealing with diffuse kind of demyelination or axonal injury in the CNS, which could also happen following an infection. And finally, what kind of infection which are we dealing with? We are not sure. We will have to dig deep. And it might not be infection at all. It may be just prodromal illness of whatever underlying diseases. And finally, basic things being basic, we would like to know the vitals of the patient. We would like to know any electrolyte derangements. How is the glucose? How is the oxygenation? How is there uremia? Things like that, which could cause these glucose levels. So that would be my approach to figure out what happened first and how are we tying in the CNS symptoms. So what do you think, Rabi? Any other insights?
No, Kirtan, I think that you analyzed it so perfectly that I'm only inclined to share what I was thinking when Simi only mentioned the first sentence. And I think it's very interesting that Simi is choosing to tell us the now and then also what happened 11 days ago. And I think the job is actually very difficult if you really restrict yourself to the now. And I say for all of you, it's really important to be as rigorous in your analysis of what you see in front of you, because the history is always subject to memory loss, inaccurate data. Like we don't really know for sure that any of these things happen. We know for sure that we have a young woman who's in a coma who's being mechanically ventilated. So my mind was analyzing this statement with much more scrutiny than the rest of the statement, because the rest of the information may be subject to a much higher chance of error than what I see with my own eyes. And I think it's very interesting that Simi has told us that she's in a comatose state on mechanical ventilation. And I think it would be premature to assume that she is in a coma state. She is on mechanical ventilation because of a coma state. Most people who are on mechanical ventilation on a comatose state are in a medical induced coma as a result of pharmacological treatment to allow them to tolerate the mechanical ventilation. So I want you all to imagine what it would be like if you were walking in and taking care of this patient. You would see that she is not responsive and that she is on mechanical ventilation. And the first thing you'd want to know is what was her medication list and what is she receiving? And if she is too sedated, i.e., is not alert, interactive, talking to you, you would want to wean that sedation. So that's the most important thing is she in a comatose state induced by mechanical ventilation, or was she intubated for a comatose state is going to be very key. And you can try to figure that out right then and there by remembering the 4 indications for mechanical ventilation. The first indication is hypercarbic respiratory failure as a result of a COPD exacerbation, for example. The second is hypoxemic respiratory failure as a result of severe pneumonia, for example. The third and fourth are all under the neurological umbrella, and the neurological umbrella is that there is such severe neurological dysfunction that the patient can no longer protect her airway, and so she is intubated for safety reasons in a prophylactic manner. And last but not least, sometimes the exact opposite happens where a patient isn't intubated because of a depressed mental status, but they're intubated for a hyperactive, hard to control mental status and intubated and sedated for their safety to allow diagnostic tests, etc., to perform. So there are 4 indications for mechanical ventilation: hypercarbia, hypoxemia, depressed mental status, and an hyperagitated mental status. And so we'll have to be very, very prescriptive about why she was intubated. And if we don't know why, then the way you can figure it out is to see how is she participating with the vent? Is she breathing good, oxygenating good, and what is her mental status right now? So that analysis will be merged with what Kirtan said about the prodromal illness to help us make progress. So I'll hand the mic to you, Simi, to tell us more.
Great thoughts. And now I'll give you some more information and then exam findings and some vitals. So the patient was first brought to the outside hospital 4 days after the symptoms started, and where she was noted to be weak, following commands intermittently, and was having voice changes. As per her caregiver, she coughed some ice chips, followed by saturation to 50s and 60s, and then she was intubated, like we were discussing. And during her stay at the hospital, her condition worsened and she was brought to our facility. And I'll also give some past medical history and vital and exam findings. She has past medical history of bipolar disorder, schizophrenia, and microcephaly, which is seen only on MRI. And patient has no past uh, significant family history. And she has cognitive impairment, but no mobility impairment. Her medications include ziprasidone, 20 mg daily, and paliperidone, 9 mg daily. And as for the vitals, patient's BP is 124/94. Her respiratory rate is 14, and temperature is also normal. On general examination, she was intubated but not sedated. Skin examination was normal. Head and neck examination was normal. On cardiovascular exam, we found tachycardia but no murmurs. On pulmonary exam, there were bilateral crackles and extremities were well perfused with no peripheral edema. As for the neurological exam, patient was unresponsive to commands and pupils were 6 millimeter and non-reactive to light. Corneal reflex and calyrex reflex were absent, and areflexia was bilateral, and we had mute toes with no plantar response, and there was no response to pain in any extremity. And I'll stop here, and I would love to hear your thoughts.
Incredible, Simi. Thank you so much. Yeah, Kirtan, I'm really curious. What have you latched onto here?
All right. And firstly, I wanted to thank you, Seema, for presenting case in like such a lucid manner that we don't lose the train of thought. So thank you for that. So we were interested in knowing the background of this patient and the drug history which this patient was taking. And it was cute. It was interesting that patient had bipolar disorder, and immediately you would think that lithium has to be implicated. But then, as we know over the years, nowadays we don't use lithium that much because we have powerful second generation antipsychotics, which are as good as lithium in controlling the symptoms. So glad to know that this patient was not on lithium and patient was on ziprasidone and palaperidone. Now, always our instinct is to tie in all the symptoms from a unifying diagnosis, and we would jump to the drugs if they are implicated or not. So usually antipsychotic drugs can cause many extrapyramidal side effects and metabolic side effects, but they are not known to cause diffuse cerebral injury, at least in isolation. If the patient has concurrent abuse of any other drugs, like let's say benzodiazepines, tricyclic antidepressants, or any other drugs, then we might see some degree of CNS injury. But with the current medication alone, it's less likely. So now focusing on the examination, the point which Rabi raised in the first record, like very amazing point, that is the patient sedated or not. So now we know for sure that patient was not sedated, and still on examination, patient is unresponsiveness and all the brainstem reflexes are not present. So this points to the fact that there is global cerebral dysfunction, including possibly at the level of brainstem itself. So in medicine, the way we have learned over the years is that whenever we hear a buzzword, our mind starts creating the differential diagnosis. That's why we come up with problem representation and we try to give a tag to whatever we are seeing. Although it may not be accurate at the first sight, but at least we try to give a preliminary tag. So in this case, what would be the preliminary tag to what's going on with our patient? So we will say it's a young lady with rapid onset of diffuse cerebral injury, and likely we could frame it as meningoencephalitis or rhombencephalitis. The reason why I'm using the word rhombencephalitis, because rhombencephalitis means inflammation of the posterior aspect of the brain, which would include the brainstem and cerebellum. And often, since the brainstem contains the nuclei of various cranial nerves, we could imagine how your corneal reflexes, how your caloric reflexes could be impaired if there is dysfunction of the brainstem. So now, once we have the rhombencephalitis term in our mind, our brain will start generating the differential diagnosis of what could be going on. The other point which I wanted to raise was that this patient has normal vitals, which means that at least the autonomic dysfunction is not present yet. And CMA hasn't told us anything about vasopressor requirements. So we are presuming as of now that this blood pressure is on its own without any vasopressor. So which is good, but that is also something which we should keep in mind, that down the line, patient might become autonomically unstable and you might need vasopressor requirement. Regarding the diagnostic progress, so of course, in terms of labs, you would still like to know that how is the basic metabolic panel. So is there severe acidosis? Is there severe hypoglycemia? Is there severe hypercarbia on VBG, which could explain some of these findings? We would like to get ammonia levels. We would like to see the BUN levels. We would like to get the urine toxicology screen. And then once we have done all of that, I will have to discuss with Rabi that what will be the utility of getting the CSF to rule out the autoinflammatory causes and infectious causes. So what do you think, Rabi?
I think it's incredible what you've accomplished because you're now much more confident that this is a disease that is localized to the brainstem by the outstanding example that you had, outstanding analysis that you just had. And I think we heard you do was you were saying, okay, I know for a fact it's brainstem. And then you said, I'm open to two other clues. One is brainstem with dysautonomia. And what does that mean? What clues does that give me? And then brainstem with or without systemic disease. I completely agree with you that the problem representation is almost complete, but we really need to understand, is there any other evidence of neurological disease elsewhere, including in the autonomic nervous system? And so is this isolated brainstem disease neurologically? And then is this isolated brainstem disease systemically? And I think that you ask yourself, is there anything you need to know now before you can accumulate these informations? And I think that if this were an older person, you'd be very, very open to the possibility that they had a devastating Basler syndrome, or that they have if they were much younger, that they have a large compressive space occupying process. So I think the workup for a brainstem dysfunction syndrome moves fairly quickly to rule out a compressive etiology and to rule out a vascular etiology. And so I think, like you said, we need to know, are there other neurological features? Is this patient systemically active or not? But even though the time course is not necessarily compatible with a compressive etiology or vascular etiology, I imagine a CTA or an MRA will be on people's radar in parallel to the labs. In fact, if you received this patient like this from another hospital without any documentation, you would much prefer that she goes through the scanner before she comes to your ICU. So I'm right there with you, defining where else is affected and understanding the brainstem, vascular, compressive, inflammatory, or bland. And I think those categories will help us a lot. So let me hand the mic to Simi to give you the data you're looking for, my friend.
Very rich discussion, and I have some more information for you. So we got in EKG for this patient. We showed sinus tachycardia. Chest X-ray showed only mild pleural effusion, which was not clinically significant. And Kirtan wanted ammonia level and electrolytes. They were within the normal range. And also burn creatinine, they were normal. And we also got WBC for this patient, and they were 19,000 elevated with neutrophilic predominance. And hemoglobin was 9.1. Platelets were 158. Lactate level was normal, and CRP was elevated at 16.8. And ESR was also elevated at 123. And I would stop here. Would you like me to share the MRI findings right now, or I can bring for you in the next aliquot as you prefer?
Yeah, whatever you had planned. So why don't we just hear Kirtan's analysis of the slabs and then we can go on. So what do you think, Kirtan?
Perfect. So thank you so much for the basic data. Now we know that the focus is on neutrophilic leukocytosis and inflammatory signature we have as evidenced by high CRP and ESR. It is reassuring that the basic metabolic things like acidosis, hypoglycemia, ammonemia has been ruled out, at least as of now. So what can we make with the WBC and this? So as we were saying initially that if we believe that this prodromal illness of sore throat, diarrhea did actually happen, we should confirm it, of course. And if it did happen, then we start wondering that is this a post-infectious sequelae or not? And as we were discussing initially, that people can have something known as ADAM, which is acute disseminated encephalomyelitis following any kind of infection, which is basically autoimmune directed diffuse injury. And since the myelination is everywhere, it could affect your brainstem, it could affect your cortex and can cause global cerebral dysfunction. And the fact that there is still inflammation further points to the fact that this could be a fair differential to consider. So that was my first thought. The other possibility is that when we say rhombencephalitis, we try to define as infectious causes and autoimmune causes. And in the infectious causes, we often think about the classic viruses and some parasitic or tick-borne diseases. Now, the fact that patients' platelets are normal is helpful in this context because so many tick-borne disorders, whether they are tick-borne viruses or intracellular organisms like, let's say, Escherichia, Anaplasma, all of them tend to cause some degree of thrombocytopenia and leukopenia. So the fact that we don't have that kind of makes them less suspicious. Although these findings are not pathognomonic, but for the clinical reasoning perspective, we can say that maybe it's not one of the tick-borne disorders. Then what else it could be? So classic viral disorders, in a young person, you would think about HSV, VZV, CMV, so herpes group of viruses. If there were concurrent exposures, then we can think about arboviruses also, like let's say West Nile virus, Japanese encephalitis, equine encephalitis. All these viruses have tendency to go to the brainstem. So that's why, and given the high SICRP, we have to presume that it could be meningoencephalitis. What about bacterial causes? So of course, if there is florid basilar meningitis going on from any of the classic bacteria, it could be strep, it could be Haemophilus, any of them, they can also present in this manner. And down the line, the imaging studies and CSF would shed a light on that. So once we talked about this, what about some autoimmune causes? So in a young lady, you should always consider at least lupus because lupus can cause devastating cerebral injury. You don't want to miss that. Under the demyelinating category, we would like to think about could it be NMO? Could it be MOG related demyelination? Because we have seen many cases, and I think Dr. Berkovich raises this point often, that whenever you think about ADAM, also think about ADAM mimics. So what are the ADAM mimics? So usually fulminant MOG associated demyelination, and then rarely like CNS, HLH are considered as the differentials of ADAM. So whenever you see fulminant injury, you got to consider this if the imaging findings are persistent. Now, the last question becomes, this is very kind of analogous that we often think about imaging negative abdominal pain. So you could think about, what about MRI negative CNS syndrome? If somebody has such devastating injury going on, you get the MRI with contrast and it's completely clean. Let's say you don't see any evidence of T2 flare intensities in the brainstem, no evidence of infarcts on DWI sequence, then what would you think? So then you start wondering that could this be a toxin mediated process or could this be an antibody mediated process? And the reason why I raised the question of antibody mediated process is because This person had some prodromal illness and there was some weakness. Now, we don't know what kind of weakness it was initially because patient was presumably too sick. But if we say for sure that that weakness was not just fatigue, but it was neuronal in nature, which means patient had peripheral nervous system injury, then you start wondering mimics of GBS, which goes in the CNS. So the classic examples, as we know, would be Bickerstaff brainstem encephalitis, and which is known to cause encephalitis as well. So, and usually Bickerstaff brainstem encephalitis may not cause any kind of injury on the imaging. It can have some imaging findings, but it could be negative as well. And similarly, as Rabi was saying, could there be neuromuscular disorder? So botulism is another example of how it can cause such devastating injury without leaving a mark on the MRI. So that is how I will proceed. That first we will get the imaging, see if there are any classic imaging findings. We can get the CSF to rule out the classic infectious causes, some serologists to rule out the autoimmune causes. And then if imaging is negative, then we would engage in discussion with the neurology to get more insights regarding what kind of antibody mediated process could cause such devastating injury. So what do you think, Rabi? How should be our sequence?
I think that your analysis incorporates a really important fact here, which is that you incorporated things that would be inflammatory in nature by virtue of the neutrophilic leukocytosis. But many of the things that you said at the end, especially, will not have a signature on MRI, nor will they have a signature stereotypically on the CBC and cause a dense neutrophilia. So I'm going to try to see if I can get this out of you. How how would you, if this turns out to be Bickerstaff encephalitis, which it certainly looks like it is, how would you then explain the neutrophilia?
Right, you are right. So that would be a little bit unusual. And then we might have to think that
It's not unusual. I
yeah.
promise you.
Oh,
Remember, where is the neutrophilia coming from? She had a massive aspiration event, right?
oh, sure.
So you have to be careful. And I think
Mm.
your mind already knows that because you did not restrict your analysis to conditions that require a neutrophilia. And I think there's just a small but very practical learning point here, Kirtan, which is that the presence of neutrophilia in a neurological syndrome is either a signature of the underlying disease or unfortunately a very common and somewhat irritating distractor by the high prevalence of pharyngeal dysfunction and subsequent aspiration induced. So you cannot take this neutrophilia to the bank. It may be a clue to an aggressive bacterial rhomboencephalitis, or it may be totally distracting you and taking you off straight and not a marker of the disease. So I'm really glad that you did not restrict your categories to just things that require this finding. This finding may be a pure distractor. Uh, and so that's why it's really important to know the event settings. You know, when she's but anyway, I don't want to belabor it too much. But yeah, don't I'm glad you didn't lock into the neutrophilia. It either could be a clue or it could be a complete distractor. And the way we proceed is exactly how you said. I'm right there with you, my friend. All right, Simi, take it away.
Great discussion and great thoughts. So I have some more imaging findings and CSF findings for you as requested. So the glucose, protein, WBC, RBC in the CSF were normal. We just had elevated IgG index of 4.8, which was high. Other than that, there were no oligoclonal bands and nothing on the CSF that was abnormal. We also checked for West Nile virus, which was negative. We got HIV test of which was negative, and we got blood cultures, which were negative. I also have CT and MRI findings. So CT showed mucosal thickening with air fluid levels in sphenoid sinus consistent with sinusitis, and there was mild cerebral and cerebellar atrophy. On MRI, we had microcephaly, which is a chronic finding for this patient, and there was mild parenchymal volume loss. And I'll stop here and would love to hear your thoughts and let me know any further tests that you want.
You almost predicted the normal MRI, huh? Nice job. Okay, take it away, my friend. What are you thinking?
Perfect. So this information is very helpful that we were able to get the basic testing, like if there was CSF pleocytosis, like raging neutrophilic pleocytosis, immediately we would start wondering, giving some antibiotics before going down the rabbit hole of which infection it is. But fortunately, the CSF looks okay. And now this is also a very important point that sometimes you see people who have peripheral leukopenia or from, let's say, hematologic malignancy or any other cause, and then their CSF counts are also low. And often that is because there is not enough WBC in the periphery. Then how would your CSF mount a response? Or let's say if the patient was immunocompromised from some kind of major drugs, like let's say rituximab or steroids, MMF, then you could imagine that maybe the body is not mounting adequate response. But as of now, we know that this person is not on any culprit medications to cause leukopenia. The CBC in the blood is not showing leukopenia, and patient doesn't have HIV. So once you take out all of these factors, and despite that CSF is completely normal, makes you feel a little bit easier, makes you breathe easy, that there is not a fulminant infection, bacterial infection, which is killing the patient right away. Now, having said that, the fact that person has high IgG index, what does it mean? So high IgG index means that there is intrathecal production of immunoglobulins, which classically means that there is some degree of inflammation in the CNS, which is directing the production of these antibodies. And usually in infection, this could be something which we don't usually check, because in infection, we have other evidence in terms of pleocytosis. So whenever we check the IgG index, we're actually looking for the autoimmune causes. And the classic autoimmune disorder to cause high IgG index is, we think about multiple sclerosis. And multiple sclerosis would leave a particular signature on the MRI, which we don't have. And usually classical variants of MS tends to present subacutely or chronically. So that one of the most common causes out of the picture. What about other common causes? So other demyelinating disorders, which we were discussing earlier, like neuromyelitis optica or MOG-associated demyelination, they can have a high IgG index, but again, you could imagine they cause demyelination, and some of them may not have imaging findings in the very initial phase, but if they have reached to the point of causing comatose state, then you would expect some imaging findings. So that is also out of the picture. So now you come to the final part, that imaging negative causes, so toxins and antibody mediated disorders. Now in toxins, whether it is some sort of heavy metal toxicity, whether it is some sort of tick-borne toxin, or whether it is, let's say, botulism, it is toxin itself is causing the damage. It does not cause the autoimmunity, which means it doesn't allow your WBCs to react to it. So why would you expect the IgG production in the CSF? So that equation also becomes less likely, although not impossible, and we would explore the territory down the line if we don't find any other answer. And then the antibody-mediated disorders. So in antibody-mediated disorders, classically we think about paraneoplastic mediated disorders. So we have a host of neuronal antibodies, the most common being NMDAR, LGI1, and then a ton of others. And sometimes many of them actually do not leave any kind of sequel on MRI. So classic rhomboencephalitis antibodies would be anti-MA2 antibodies, anti-Re antibodies, anti-Hu antibodies, KLH antibodies. And the reason why I'm mentioning these antibodies is important because young people tend to have thymomas, they tend to have teratomas, they tend to have germ cell tumors. And all of these tumors, which I have mentioned, are known to cause antibodies like anti-Hu antibody, anti-Re antibodies, which can cause CNS damage. So we should keep them at the back of our mind, knowing that the prognosis is related to the underlying tumor and you could be saving somebody's life from tumor. So although it is rare, we should keep it at the back of our mind. What about other antibodies which are not paraneoplastic? So then comes this final disorders related to GBS spectrum, so which would be like Bickerstaff brain stem encephalitis. And classic antibodies are anti-GQ1B antibodies, but in some people you can get GM1 antibodies, GD1 antibodies as well, and they can cause such high IgG index. Now, other question might arise that we have all been learned to think that people should have cytoalbinologic dissociation in CSF when we are dealing with GBS spectrum disorder. Why don't we have that yet? So now again, if we look at the very well crafted studies in people with Bickerstaff encephalitis, this cytoalbinologic dissociation is like not concrete. And especially if you check it early on, it may not be present. So you might want to consider that. You might want to ask neurology that what should we make of this dissociation? And the last point for which I want Rabih's insight is that the classic description of Bickerstaff encephalitis is that they tend to have some degree of hyperreflexia. Now, this is also not certain because it also depends on what time you are checking the patient. But I would be curious to know from Rabih that the fact that patient has areflexia, Does that add any other differentials to your mind?
Kirtan, that was absolutely amazing. I think that I hope you realize that your ability to articulate your thinking in this case is very, very unique because it requires so much medical knowledge, but it also requires medical knowledge at the interface of internal medicine and neurology. And there are very, very few people who are able to understand how to synthesize a syndrome just like Bickerstaff, which exists at the juncture of medicine and neurology and requires you to understand fundamentally internal medicine concepts with deep, deep neurology. Um, I think that if I were to summarize the progress that we made, we started with just imagining this case the hardest it's possible, where you are rapid response and you walk in and you see somebody comatose intubated. You do a good neurological exam, you say brainstem based on the excellent neuro exam that's being presented. And then you say brainstem, I want you all to have a checklist: compression, vascular, then inflammation. So you scan her, you see no compression, no vascular disease. So now you're prioritizing inflammation. And the question is, well, what kind of inflammation? And Kirtan taught you something really, really important. He's right. Most of the time, you will see why a patient is comatose when you take a look in their brain with an MRI. Even if they have a primary meningoencephalitis issue, they often have concomitant MRI clues. And just to arm you with some examples, just to make the point. So in West Nile virus, you often have thalamic disease. In HSV encephalitis, you often have temporal lobe disease, so on and so forth. So how could it be? How is it possible that in 21st century technology, an MRI cannot see why your patient is in a coma? And there's one very simple answer. The disease is at the molecular level, be it a molecule that is a toxin, a molecule that is an antibody, or finally, and importantly, acutely, is that your issue is electrical and that you are in non-convulsive status epilepticus. Those three things. Now, there are some other molecules. I didn't give you the full list, but prion disease is another example, though that often shows up on MRI, but you need a good radiologist to spot the subtle clues. So I just want you to take away very simple. If you cannot find why somebody's in a coma on an MRI, that's because you have a molecule. And how do you diagnose diseases mediated by molecules? Very simple. You look in the patient's pill box for the molecules that she is taking, or you call the lab to help you find the antibody that's causing the disease. And so I think that's the very kind of simplistic take of this case. Now, if we zoom in on details, it matters what antibody we're suspecting, and we're suspecting antibody-mediated disease based on the features in this case, but also based on the fact that the patient doesn't have any compatible molecules in her pill box that cause a syndrome like this. And so um, I think the very simplistic approach of antibody-mediated disease is to ask yourself, what is the trigger? And the most important triggers are cancers, but a trigger can be a parallel systemic autoimmune disease like lupus, triggering NMO as an example. And then, of course, a trigger can actually be an infection. So HSV encephalitis is notorious to trigger NMDA encephalitis as an example. So if you're thinking, oh, my patient has antibody-mediated disease, is it primary or secondary? And secondary diseases are really important to analyze because you will not be able to stop the disease unless you address the secondary culprit, often cancer, but occasionally autoimmune or infection. So that's why it's really important to be particular about what kind of antibody you're looking for. And that's why it's really important to get a systemic signature of what's going on, even if it's subtle. These patients often get CT scans and PET scans just to make sure that there isn't a small ovarian teratoma, as an example. But to zoom in on your question, Kirtan, I think it's very, very powerful that this patient has areflexia. And based on an outstanding case that Charmine published with other CP Solvers team members, the presence of depressed reflexes in a patient with a devastating brainstem disease is often a powerful clue to Bickerstaff encephalitis. And it's one of the very few subtle clues that can implicate that disease over anything else. So, like you, I think I just should be clear, hyperreflexia is expected to occur in all devastating brainstem diseases, absent acute brainstem shock from trauma or vascular injury. But 11 days into the disease process, most brainstem diseases have had the opportunity to change the reflexes into hyperreflexia. And so if she's still areflexic, I would be very, very suspicious of Bickerstaff encephalitis. And I think that this is the beauty of that disease, because I think you can do some unique tests to pull it out, including, of course, the ganglioside antibody analysis. But I'm really curious, Kirtan, are there any tools in your toolbox that you can do in addition to antibodies to help you be even more suspicious of something on the GBS spectrum?
Right, Abhi. So from what I know, that once I even presented the case of bigger stuff before, and at that time also we were discussing that if the patient was, let's say, at least in a semi-conscious state, then maybe you can do some like testing, like you can check the diaphragmatic motion, you can do the negative inspiratory force testing. But if somebody is already ventilated, maybe there is not much utility there. And I think what you said is that's what we also came along previous time, that if the imaging is negative and you get these reflexes, you have the CSF signature, then, and of course, you will rule out all the extensive infections by PCR testing, not just by antibody testing. And I think that should be it. But any other clues, Ravi, that you think we should keep in mind?
Yeah, I think the only thing that people might consider is doing an EMG. And if you
Mm.
see in Bickerstaff encephalitis, it is essentially on the spectrum of diseases related to on the spectrum of diseases causing acute inflammatory demyelinating polyneuropathy. And about half of patients have characteristic features of their EMG in Bickerstaff encephalitis. And so you might be able to see oh, I'm not sure where that voice is coming from. You might be able to see EMG evidence of this disease process. So I think this patient's case is very strong, where you would probably start empiric IVIG, and I don't think you need any other diagnostic tests to start treatment. And then I think the tools in your toolbox are EMG and ganglioside antibody analysis, and then just being open to, if it's not a Bickerstaff, then the next most important step is to get extensive visceral imaging to make sure that there's no tumor that we need to address. Any other thoughts, Kirtan, before we hear from Simi?
No, I think I'm right there with you. That sequence should be to include the neurology on the board so that they can
Yes.
guide further testing from CSF and serum. And all these antibodies we mentioned, like RI, MA, all of them are paraneoplastic. So you want to consider them. And toxins also, ask the toxicologist if you have them at your hospital, that any toxins that they could think of which could cause this, but it would be a little bit unusual. So yeah, our final diagnostic test, as they say in journals, would be obtaining the serum ganglioside antibody panel and trying to see if the empiric treatment results in improvement. That would be the final clue. And maybe I'm curious to hear from you, Sammy, before you tell us the answer, that how was it like for you to take care of this patient, and what were your differentials and your team's differentials at that point in time?
I think great thoughts and great discussion. And the team actually started IVIG, as Rabi mentioned, for this patient. And we were thinking around the lines of GBS at this moment. And before getting any ganglioside testing, we got electromyography and nerve conduction studies for this patient. And on electromyography, there was no motor response, even on repetitive stimulation, and nerve conduction studies showed no motor responses in this patient. And I'll stop here and would love to hear your thoughts.
Go
Sure.
ahead.
So perfect. So as we are discussing in the previous aliquot, that if this person had weakness, which was true neurological weakness, and not just because of being like in a semi-conscious state, then we knew that the autoimmune attack was first at the peripheral nervous system, and then it got transferred to the CNS. So which is very like kind of like form a first for GBS spectrum disorder. And as Rabi said, that EMG would be your last tool in the toolbox, right? So the fact that there are no motor response, and this is also important point I wanted to make, and this is something which we discussed with Dr. Berkowitz last time when we were going down the rabbit hole of nitty-gritties of Bickerstaff, that the most common version of GBS that we see in routine practice is so-called AIDP, which is acute inflammatory demyelinating polyradicular neuropathy. But then there are so many versions of GBS in which you have axonal injury, which is predominating. So in bigger stuff, actually, the demyelinating version is not as common as in the normal GBS. And in fact, the axonal variants and the motor variants are more common. So the fact that in our case, the patient had this axonal injury and motor injury kind of further raises the suspicion for Baker staph encephalitis. And another subtle point I wanted to make was this urinary incontinence thing. Now, usually this is one of the differentiating feature as well, that they always ask this in the board exams. That GBS, how do you differentiate it from, let's say, transverse myelitis, which is another common mimics? So bowel bladder disturbances in GBS are less common or unlikely. Whereas when you go down the Baker staph route, since it's the CNS injury, not the peripheral injury, you could get bowel bladder incontinence or some disturbances regarding that. So if we believe that all the symptoms which we had at the first time were absolutely true and representative, then this makes a perfect case for because of having that EMG now.
Agree with excellent attending note. By the way, you're ready for like big stages in clinical problem solving, like big grand rounds or whatever, when you say form fruste. So what more what can I say after that? Mike, to you, see me. Outstanding job, my friend.
So, after getting the EMG, the team was thinking around the lines of some neuromuscular disorder, and serum specimen was sent for this patient, and also a mouse bioassay was performed, and the mice who received the patient's serum died. And I'll stop here. I would love to hear your thoughts, and in the next aliquot, I'll reveal the final diagnosis.
Ravi, I would lean on you to shed light more that mouse died now, which could, yeah, which could
I
possibly
think you
mean
have to
that,
go to your toxin category now, my friend.
yeah, like antibodies can of course cause devastating injury to the brainstem and make you die, but usually, which is that's not the expected response that somebody dies.
Uh,
So yeah, we would have to include the toxicologist and I think going down the rabbit hole of toxins. So we did say botulism initially. Apart from botulism, what else it could be we could think about? So heavy metals in general, this is probably too fast for heavy metals. If it was any gas, like let's say I can't think of any gas just like that which would do this. Like there are some organophosphorus neurotoxins which people would be exposed to if they are in pesticide industries, and they are known as now gas, and they classically causes defect at the neuromuscular junction, and in the high levels can end up into your brainstem. But still it would be hard to imagine because at least in our case so far, we don't have any signature from occupation unless unfortunately this was like a toxin attempt to like kill someone. That would be a whole different story. So what I would like to get at least the urine heavy metal screen, okay, and then even in the VBG we didn't see any funky blood gas abnormalities to suggest methemoglobin, sulfhemoglobin, anything like that, so that is also unlikely. And it's hard to imagine what kind of toxin would give you signature on the EMG. So any other heavy metals which mimics the GBS. So arsenic toxicity can mimic GBS. It can cause axonal neuropathy as well. But as far as I know, I am not sure if arsenic can go to your brainstem within matter of 10 days. It should cause global cerebral decline over the course of months. So, but still, I would like to get at least the arsenic levels from the blood, urine, and the hair as well, because that is one of the closest mimics of GBS. If this person took any fishes by any chance, like shellfish, like paralytic shellfish poisoning, neurotoxic shellfish poisoning, but I don't see any evidence of that here. Like there are tons of toxins like Sigma teratoxin and batrachotoxin and whatnot, but we don't have evidence there. In the viral category, I would mention this that although CMET told us that enterovirus PCR was negative, at least one other virus we should check for is rabies, because rabies has two different forms, and one of the rabies form is known as neuroinvasive form and another is known as neurotrophic form. So the neurotrophic form actually mimics West Nile, that it causes the paralysis rather than hydrophobia and all that stuff which we learn in med school. So we would like to get the rabies testing to make sure we are not missing that. And then apart from botulism, I can't think of anything else. What do you think, Ravi?
See me, you made him nervous. See how many diagnoses he had to say at the end. But don't worry, Kirtan. I think you got the answer, in my opinion. I don't know the answer, but in my opinion, I um I think this case is really, really important because it shows you that if you don't have the problem that you're solving correctly, you solve the wrong answer. So you ask yourself, do I really know that this patient has brainstem disease? And I think that's a really important question to ask because she could have such a severe systemic weakness issue that has rendered her essentially, well, I should say it differently. I think that um, when you have a profound weakness syndrome peripherally, as this EMG demonstrates, and you literally are basically paralyzed, it becomes very difficult and nuanced to say, are you responsive or not? And you might go back to that neuro exam, Kirtan, and say, is she not responding to pain because she is centrally compromised, or is it because she has no strength? Is she pupils dilated because she is centrally compromised, or she has autonomic dysfunction of the pupil? So, part of moving and making progress in medicine is to realize what space you're in. And I think once you are open to that possibility and reframe the case in light of unexpected findings, you might come to the conclusion that maybe she actually isn't having any brainstem problems. And if you reformulate this case and you say, I have a extensive deep paralysis syndrome restricted to the motor space, just the motor space on EMG, with associated pupillary abnormalities. Guillain-Barré, Miller-Fisher, Bickerstaff don't usually cause prominent pupillary abnormalities. It's one of the things that argues against them. So I think for me, the mistake that I made was to definitively conclude that her neurological exam is from a brainstem issue, and it really might just be that she just has no pupillary function because her acetylcholine is completely poisoned by botulism. And I think that that would be, like you, my leading diagnosis. But in parallel, I'm asking myself, why did this happen to her? Why did she get botulism? She doesn't seem to have any wounds. We don't know of any specific ingestions that she has, though of course that might be missing. And finally, with her microcephaly, you can easily imagine that her gut motility is probably not great, so she might have um, botulism associated with a specific kind of Clostridium that can colonize people with poor gastrointestinal motility. But for me, Kirtan, I think that the problem representation of a brainstem disease might not have been accurate. And I think the severe peripheral nervous system dysfunction resulting in severe paralysis is the likely true problem, in which case botulism, as you suggested, becomes the most concerning answer. So that's probably what I would definitely treat her with botulinum toxin, and I would tell her family I don't think we're gonna know what's gonna happen for maybe weeks or months, as her neurons are permanently poisoned and require regeneration for her to turn to recover. Simi, what did you find?
So you guys are on point. It was actually botulism, and the serum specimen showed botulism. And I also have some good news that the mice who received serum with botulism antitoxin survived, and those with the patient serum died. And I think it was great discussion, and I did not actually see this patient, Dr. Rabi was very kind to share this amazing case with me, and it was so well organized that I felt like I was actually taking care of this patient, and it was great having you guys discuss this case. Got to learn a lot.
I think you presented it as if you were taking care of the patient, Amy. I can't believe you put this together in 24 hours. That was absolutely outstanding. Really, really nice job. So, Kirtan, what are your reflections?
Well, it was a good journey that the first point which you raised, very nice, that we have to understand what happened before the event. The second point you raised, that whether the patient is sedated or not, that was very good. And I think we did a very good analysis that we were focused on ruling out the most common causes. So as you said, vascular and compressive, we ruled that out. And we went down the CSF route to make sure it's not bacterial cause. We ruled that out. And then I think we also framed that part very nicely, that if the MRI was clean, what would we think about? So we did say that either it would be antibody mediated or it would be toxins. And in the toxins, we were saying that we should get toxicologists involved to make sure that we are not missing any toxins. And we were concerned about botulism as well. I think probably the only reason why, if it was like 1 versus 2, why we were focusing antibody mediated versus botulism was maybe because of IgG intrathecal response. Now, of course, it is described in botulism, but maybe it is not as pronounced as in antibody mediated. And the other possibility is that why maybe we were misled was that usually botulism is an NMJ disorder. So if you do a well organized EMG study, it should not show you motor neuropathy like axonal injury or anything like that. It should show you that on repetitive nerve stimulation, maybe there is decremental response, which would be analogous to what you see in, let's say, myasthenia. So, but again, EMG is not a complete science. Sometimes it's very difficult to perform EMG, especially when the patient is like, let's say, in comatose state. So maybe interpretation could be a little bit different. But otherwise, I think the key takeaway from this case would be the same thing, that if a devastating injury and normal MRI and relatively unremarkable CSF, then you are left with toxins and antibodies, and then toxins causing neuronal injury acutely, some heavy metals, and then botulism. So I think that should be the summary.
Absolutely outstanding summary. I couldn't agree more with you. My biggest takeaway is that it is very, very hard to distinguish and devastating peripheral syndrome that knocks out autonomic and muscle tone from a brainstem disease. Very, very hard. And I think that's the tension in this case that I had very extreme difficulty with. I really appreciate you narrating the journey and the learning points. Kirtan, I'm excited for Manahil to do the same. So, Mike, to you, Manahil.
Thank you, Simi, for presenting this case, and shout out to Kirtan for his long list of DDs and antibodies he mentioned. So I will start my teaching point. At first, like, patient is a young patient, that is like a red flag, and we have to take that in consideration, that whether this patient has acute or chronic condition or it's the acute presentation. We will look into his past medical history, his medications, like benzodiazepine can cause this. Then next is patient is comatose. So what can be the causes? It can be due to bilateral thalamic involvement, global cortical, or brainstem involvement. Then we have a list of the causes. It can be infection and autoimmune disease traveling from peripheral system to the central system, or any demyelinating disease involving an infection. This patient is on vent. So Ravi discussed the 4 indications for mechanical ventilation. That number 1 is hypercarbic respiratory failure. Second is hypoxemic respiratory failure. Then third, we have depressed mental status, or patient is on hyperagitative mental status. So whenever you see a patient on a vent, we have to ask that it is coma induced or patient is intubated due to the comatose state. In our case, patient was not sedated, so it's most likely global dysfunction. And here we have 2 DDs, that is meningoencephalitis or rhomboencephalitis. So in rhomboencephalitis, basically there are nuclei of the cranial nerves that are affected. Common causes of rhomboencephalitis can be infections, autoimmune or demyelinating disorders. Then we have to rule out the causes, like whether patient have ARS dysfunction, we have to look for the vitals to rule out this. Then whether it is brainstem dysautonomia or brainstem with systemic involvement. Then we have to rule out 3 etiologies. It is compressive, it is vascular, or inflammatory. And imaging that will help us is CT and MRI. But if our MRI is negative, then what is MRI like? What will be our details? So it can be toxin mediated due to heavy metals, antibody mediated like paraneoplasty and GBS, or non-convalescent elliptical state. What's the pathology I want to find out why MRI is negative, why disease is progressing, that disease is still at the molecular level. So here we will look for two things. What's the medication patient is on, and we will send the antibody panel. Then we have the neutrophilic state patient is in neutrophilic state. So what does this signifies? That is patient is having any underlying disease, there is pharyngeal dysfunction and aspiration. Then we have IgG that is indicative of autoimmune diseases, like it can be MS. If patient has areflexia, then it is most likely encephalitis. And in the case of hyperreflexia, patient is having brainstem or trauma vascular injury. Then we discuss about the toxins that mediate GBS, that include organophosphate gas, arsenic, or shellfish poisoning. Last thing we discussed was that the patient have a peripheral weakness, then we have to think why patient is not responsive to pain. Is patient centrally compromised? Is his strength is compromised, or is patient is autonomic dysfunction? So that's my teaching points for today.
Oh my gosh, I'm so glad I stayed to listen to your teaching points. That was a great distillation. You had a very, very hard job with the complicated case from Simi. And then, of course, anyone who's doing teaching points with Kirtan, good luck to you. Your fingers must be very, very tired. Thank you to everyone involved. It was a real, real treat. And unfortunately, we don't have a public VMR tomorrow, but I look forward to seeing you guys next time. Bye.